Jamie and Riley have the same medical problem. They get identical care and procedures, but from different doctors. Jamie ends up owing thousands of dollars more than Riley. Why would this happen? Location, location, location. Jamie was treated in a hospital outpatient department, unlike Riley, who received care in an independent physician's office. Medicare typically pays hospital outpatient departments more than freestanding physicians' offices, even when the services are the same. This means that where a person gets their health care, especially for Part B outpatient services, can be just as important as the care they get when it comes to price. Let us break this down to explain how these payment differences incentivize hospitals to buy up physician practices and shift routine services to more expensive locations, which ultimately drives up Medicare, taxpayer, and beneficiary spending. So, what are the different locations that matter so much to these payments? There are freestanding physicians' offices, hospital outpatient departments, and ambulatory surgical centers. All three types of locations are subject to the same provider rates, but differences in payment come into play because the Medicare program assumes it's more costly to work from an ambulatory surgical center or hospital outpatient department, with hospital outpatient departments being considered the costliest. Every year, the Center for Medicare and Medicaid Services, shortened to CMS, updates their payment rates to independent healthcare practitioners who take patients with original Medicare for things like visits, tests, supplies, and procedures in the PFS. PFS stands for Physician Fee Schedule, but applies to other kinds of non-physician practitioners as well. The in-office PFS includes office expenses, since it's assumed that independent practitioners have to cover their own office expenses. What does this look like in practice? Let's go back to Riley to illustrate. These numbers are just examples, but let's say the cost of the care provided was $75, and let's say the office expenses were $25. In total, that's $100. And since Medicare cost sharing is 20% by default, we can say Riley paid $20 for this visit. But what about Jamie? Jamie went to a hospital outpatient department, a type of facility that's expected to be costlier than an independent practitioner's office or an ambulatory surgical center. When patients go to facilities like ambulatory surgical centers and hospital outpatient departments, practitioners get the out-of-office PFS, which doesn't include overhead costs, and the facility itself gets paid according to the OPPS, which stands for Outpatient Prospective Payment System. The OPPS rate can be multiple times the rate for in-office overhead costs. Let's say in this case that the OPPS rate was $105. That'd bring Jamie's total to $180, since the practitioner labor was the same rate of $75. The standard coinsurance of 20% for $180 is $36. That's nearly double what Riley paid, all because Jamie was treated at a hospital outpatient department and not at a freestanding office. Jamie paying the higher facility rate may have been unfortunate for Medicare and Jamie's own wallet, but it's not really about luck. The landscape of healthcare providers has been markedly shifting in recent years. In 2019, hospitals employed 46.9% of physicians. That portion increased by nearly 60,000 physicians by 2022, for a total of 52.1% of physicians working in hospitals and health systems, rather than independent practices. In the same time period, hospitals and health systems went from owning just 38.8% of physician practices to 53.6%, a jump of nearly 15 percentage points in just 3 years. It's no wonder that Jamie got care in a hospital outpatient department when practices are increasingly integrated into hospital systems. Hospitals and health systems have incentive to buy up practices and integrate them, because then the facility or system can cash in on the OPPS rate. This doesn't benefit the practitioners necessarily, but vertical integration of practices still impacts how practitioners refer their patients to services. If a practitioner works for a hospital system, they're more likely to refer patients to treatments and providers within that system. This keeps patients within the costlier environment, regardless of the availability or appropriateness of other standalone offices or even ambulatory surgical centers. To summarize the cycle, the OPPS incentivizes and maintains. The OPPS pays more to ambulatory surgical centers and even more to hospital outpatient departments for the same health services that a patient might get at an independent practice for a lower cost. Because health systems are aware that the OPPS pays this higher rate, they're incentivized to increase their share of business by buying up independent practices, which raises costs for the Medicare program, taxpayers, and for people with Medicare. Practitioners associated with hospitals tend to keep their patients within their hospitals for additional services, which continues to keep costs high. All the while, the care itself remains the same. Broadly speaking, site-neutral payments, that is, equal payment for equal service, regardless of the setting, has major potential to save Medicare dollars and beneficiary health expenses. Sure, there are exceptions to site neutrality when keeping a patient safe requires more specialized or complex facilities, but the underlying premise is there shouldn't be baseless overpayment for the same service. Site neutrality is a common-sense option when it comes to saving Medicare money, and it would likely have benefits for consumers covered by many kinds of insurance, since other payers often follow Medicare's lead. Medicare has a great opportunity to take steps towards site-neutral payments to save its own finances, decrease costs for Medicare beneficiaries, and make sure they're paying equally for equal care.